Good morning, everybody. I think I'm the odd guy out from the entire presentations. From pediatric dentistry to implant dentistry is quite a leap, I should say. All right. Well, I'm here to talk about some of the studies that we've been doing. I'm the director for New York Implant Institute, where we do a lot of research, a lot of studies, and I'm here to present something that is latest and greatest that you may or may not have even heard about before. Attempts have been made, but very, very unsuccessful. Immediate placements in infected sockets has been a topic of discussion for several years. A lot of success has been achieved, but what I'm doing without any debridement and any GBR or GTR processes included in the process. So when we look at science is a very, very interesting subject, I should say. We look at things differently. From when you talk to a scientific community, there are two different opinions, sometimes four. Your way of looking may be different than what I'm looking at, okay? But till the time we get to a good conclusion, that's what we really need in science. And innovations could be very, very little. It could be just a minor change that you might have made to something. But that makes a big difference. And you see all kinds of crazy ideas coming up in the literature. But at some point, if we are able to prove those crazy ideas, I think we have accomplished and contributed to that science. New York Implant Institute, like I said, we do education, research, and one of our main goals is simplicity. We try to make things simple to understand for people who don't understand the complex literature. And we provide predictability with whatever we are doing. We all live in a busy world, and the world is always getting busier every single day. When the patient comes to your practice, they always have time on their mind. They bring that clock and they put it right in your face and say, I want this thing done yesterday. Not today, I want it done yesterday. So you got to do it. And that's what brought us to immediate implant placements. There are a lot of studies. The success rate of immediate implant placement is not something new. We all know about from all these studies that there is a 95 to 98% and sometimes 100% success rate with immediate placement, depending on the study that you look at. And here is a big, long list of benefits that you can talk to your patients about. What we need to consider in implant dentistry is three different things. Number one is that implant dentistry is prosthetically driven. Surgery is important because that involves the implant fixture that gives the foundation for that restoration. And thirdly, the maintenance part of it, okay? And when we look at these factors, we look at the hierarchy in implant dentistry. This was first presented by Dr. Sonic several years ago, and he says that we have to be able to establish a baseline in order to make the restoration a success. And as you go up this ladder from here to here, you start to lose control. You start to lose control. So how about if we combined all these processes and we established a baseline right on the day one that we place the implant? Okay? That will accomplish a lot of things for us and also for our patients. Establishing a baseline requires good primary stability, bone quality, quantity, surgical techniques, and a mixture of a lot of different things that we do every day in our practices. The point I'm trying to make is that no matter what you look at, the way you look at things, the bottom line is that the patient wants those dentures immediately. They want that restoration the day off. This is the literature that we look at. Survival rate of implants, and you can see a wide variety of literature that has proved the success rate. But really, what is the bottom line? The bottom line is only one and only one thing: in immediate in immediate implant placement, and that is a good primary stability. If you get good primary stability, there is a chance, there's a 97% chance that your restoration is going to be very, very successful. Okay? We had this paper, and my entire study is based upon this, so I'm trying to create a foundation for you guys so you understand where I'm coming from. Extraction sites, Schrupp in 2003 mentioned about the significant alterations in most extraction sites that will occur in the first year. And he talks about the vertical dimensions going down by 1.5 to 2 millimeters, about 40 to 50% decrease in the socket width, with most loss occurring during the first 3 months. This is what he wrote. And the pictures that he talked about was mainly the facial plate. And as you all know, that in implant dentistry, our major concern is the mid-facial recession. That has been haunting us for years and years and years together. That is the biggest problem that we are facing in implant dentistry. Okay? Here is some more literature, but this literature from Ficky, he published a paper, and he talks about reducing the extraction trauma by limiting the flap elevation. And he says that they are essential in obtaining success in socket grafting and other bone augmentation procedures. We have other paper by Lindy and Melcher that talks about the similar thing, that elevation of a flap might diminish the ability of the periosteal cells to regenerate bone, with an undisturbed periosteum maintains an osteogenic potential. This is what it is. So here's the thing, that if we do not disturb the periosteum or the internal aspect of our socket after extraction, are we not preserving the periosteal cells? Yes? No? Maybe? Nobody wants to answer? Okay. Yeah? So, and then we look at one of the studies by Sands. He talks about the facial plate in maxillary anterior teeth. And you look at the study, and what it basically represents is that most of the facial plate is less than about 0.5 millimeters thick at any point, at any given point. Okay? So we look at these factors and these studies that have been done. Back in 1990 to 1993, there was a lot of criticism that was achieved because immediate placement actually started in 1989. Okay? The first published paper on immediate placement was in 1989, where they had shown a significant amount of success rate. However, since that time, they talked about immediate placement in infected socket, and these are some of the papers that actually criticize the fact that it cannot be done. Okay? So working in an infected area, is it possible? Yes or no? Here is the literature that supports this. But all this literature, okay, all these cited literature, basically when you go through each and every one of them, tells you that you have to, number one, debride the socket. You have to condition or do some sort of an irrigation with chlorhexidine. Okay? You have to use antibiotic. All these factors have to be taken into account to get a good success with immediate placement in infected sites. So here's another paper that Chris wrote, and conclusion was that at 24 follow-up implants placed in infected sockets rendered equally favorable soft and hard tissue integration. Soft and hard tissue. That is important to remember this in the study. Okay? There was another paper published back in 2012, and it was talked about immediate placement in infected site, a case series that concluded that based upon the study, implants placed in fresh extraction sockets affected by an infection may be a valid operative technique. Okay? Then there were several articles written about lasers. When lasers came in, people said, take this laser and start zapping your sockets. Now let me ask you, what does the laser actually do? Laser produces heat, doesn't it? We all agree? And what does the heat do? At what temperature would a cell die? an osteocyte will die at about 47 degrees Celsius, according to a lot of literature that we know about. Okay? And if that is the case, why would you zap it? Why would you kill those viable cells in the socket? That's a big question. Okay? And therefore, I came up with this immediate placement in infected sites, and this is how it all started. This was a young girl who came to my office, and she had some veneers placed some time ago. This was her radiograph. Looking at this radiograph, you can see that there is a radiolucency around number 10. For people who are not from the US, it is 2.2. 2.2, yes? I'm right? 2.2? Okay, thanks. All right. Over here, this is the cone beam radiograph. You look at number 8 and number 9 and number 10. That is 2.1 and 2.2. Okay? And this is what she presented with. Look at this cone beam right here. There is absolutely no facial wall. There's absolutely no facial wall here. The periapical area is absolutely radiolucent. That means there is no bone present. And here she looked at intraoral pictures. We gave the incision, took out the tooth. This was the defect right here. Okay? And when we started the defect, we did some bone grafting, and this was the result. This is the final picture, and I'll show you the results 16 weeks post-op. Okay? A successful integration of the implant without any scraping, without any lasers, without any antibiotics. Because when she walked into my office, she was in pain. She wanted to leave. Her husband is in the army. They were moving to South Korea. Okay? And she says, I want you to do this today. And when I come back, I'll show you my pictures. And this is how it all started. So when we look at her case, one of the critical factors that we looked at was the implant, the type of implant, how much of crestal bone we will have left after we do this, how much of a gap distance are we supposed to get. There were a lot of factors, and without going into the details, let me go to the next slide and show you what we did. This is what we did. And the hypothesis of my study was, number one, that osseointegration is possible in infected sockets. That was number one hypothesis. But it was possible without scraping, without conditioning the socket in any way or form. Okay? There is no conditioning, no scraping, no antibiotics, nothing. All the patients that were seen were patients who have non-restorable teeth. And if they were taking antibiotics, we did not do surgery until about 4 weeks. Okay? So this was our hypothesis. It's not going to be easy, but it's going to be worth it. That's what I told myself, that it is probably going to be worth it because I've done it once. I think I can do it again. Okay? So when we look at, this was our selection criteria. We looked at our sites. We looked at active infected sites with and without any drainage. It could be either one of the two. The active infection site has to be a non-restorable tooth, which means that if it was a tooth that had endodontic treatment, I would send that case to an endodontist, and I will ask him, do you think, what is the prognosis of this tooth? And only if they said it was a hopeless prognosis, that was the only time we included these teeth in the study. Okay? And they had to have a periapical lesion of some sort. They had to have some periapical pathology. Okay? So this was our criteria. The other thing that you have to keep in mind that according to Ken, he published this paper in 2010, 81% of the time we are going to find a class 1 situation in the 6 maxillary anterior teeth. That means we have a lot of palatal bone behind that to grab on and make sure that we achieve a good primary stability. And that's exactly what we followed. So we look at these cases, and I'm going to go quickly through these cases. We had a first case I'm going to present to you is with severe periodontitis with grade 2 mobility and acute infection. Patient comes in. This is number 7. This is the one that he complained about. This is what it looked like preoperatively. You can look at the topography. This is the situation. There's a slight periapical infection, not a huge one, but still there. Sorry, I can't see anything. And then what we did was we did some pre-op measurements on the CAT scan of the facial plate, the thickness of the facial wall, the length of the facial wall, keeping in reference the free gingival margin and the clinical crown length that was taken into account. We measured the width of the bony socket from facial to the buccal, from the facial to the palatal. We also took into account the entire tissue width, that is, including the soft tissue and the bone. We included that. And we took some digital impressions by Planmecca's software called Romexes, if you are aware of it. That's the software we use in the office. So here it is. I want you to look at this area and look at this little of dehiscence that is present. We extracted the tooth. Here it is. The tissue remains unchanged. We measure it for our study, and we place the implant. This is peri-op. This is 3 months post-op. Okay? And you can see in this area, look at the amount of tissue that we have actually gained in this area. Look at this topography. Hasn't changed much from when we started. Again, look at the initial. This is the final. This is the final one. This was initial. This is the final. Look at this. Nothing much has changed. As a matter of fact, if you look at the free gingival margin, it has actually moved more coronally. You see that? What a big change. And I've done nothing. I did not do anything other than implant placement and giving a patient a provisional restoration. We did not do anything. Okay? Then we look at this pre-op. Look at the topography of the facial plate here. And then we look at the topography at extraction. Nothing changes. And this is the final. Look at this. Not much has changed. And what did I do? Nothing. Other than implant placement, I did not do anything. Okay? Now we go to the next step. Look at this. This is pre-op and some of these post-op readings that we have taken. This is case number 2 with chronic apical periodontitis with vertically cracked tooth. This is number 9. This is what the patient came in for. It was referred to me by my endodontist friend, and he says, the guy wants to have an implant immediately. I said, okay, send him over. We included him in the study. This is what it looks like. Before, after. You look at this, how facially this is. According to Ken, the article published in 2010, 81% of the sockets in the sockets are usually facially placed. So we have enough room over here on the palatal. So here it is. We did the extraction, measured it, and we have enough room over here. And normally what would people do is graft the site. What did I do? Nothing. Okay? We did nothing. This is a gap distance of about 4 millimeters from the facial plate to the body of the implant. Okay? This is how it looked like. Look at the soft tissue, how nicely it contours around the area. Look at this tissue before and after. And all these crowns that have been made, they were placed subgingivally by about 2 to 3 millimeters. Okay? This is the final result. Again, this is what it looks like. Look at the amount of bone that we have gained on the facial. Isn't that amazing? We didn't do any grafting, nothing. Look at the amount of plate that we have. Here's another example. This is where we were. This is after the implant placement. Look at the difference. Okay? Here was the implant. If you put an implant and measure this length here, and you just duplicate the slide, and bring it here, this thickness was less compared to what we have here. Okay? And look at this, what happens. From here, we go to here. Okay? And there are no visual enhancement. There's no Photoshop done on any of my slides. Just a disclaimer. Okay? This is what it was. This is what we received. And this is one of the cases there where we actually have gained a tremendous amount of bone. About by 1.76 millimeters of bone was gained in this case. on the facial plate. Here's the facial bone width. We take that into account. This is another one. This is a case, and this is something that when I was doing my study, I sent it to a lot of my colleagues who do studies, and they are very critical. And I want them to be critical because I want to prove a point. So they said, look, what you're doing is you're going palatal to the actual infected area. I would like to see you go in directly into the infection and place the implants. Okay? So what we did was we placed our implants directly into the sites, and you can look at this fistula right here. This is a draining fistula. This is 8 weeks post-op, okay? And this is 24 weeks post-op. And I proved him wrong, okay? Again, I know I don't have a lot of time, but I wanted to show you these cases, wonderful cases that we have. And you can see a large amount of periapical infection with actually draining fistulas. So these are actually infections that we treated, and this is our result. So this is what we found out. When we looked at the, our data, the buccolingual width from crest to crest, you can see it's very close to where it was initially. The blue line represents the initial, and the red line represents the final. But all these values, over 50% of them, have been very, very close to what the initial situation was. Okay? The same thing over here. All these data that we have gathered over a period of time, this all tells us that we were very close to our initial situation. The average increase in width was about 0.36 millimeters. In any literature you look at in implant dentistry, it talks about the width going down. The thickness of the facial plate goes down. In our study, we actually gained 0.36 millimeters. 0.36 millimeters. Okay? And this is again data going to this. But this is what is most convincing data. When you look at this data over here, you look at our p-values, okay? If p-values are all 0.88, over here the p-value is about 0.5, that is the borderline, okay? Then over here you look at the p-values that has changed, but most of our p-values are better than usual, okay? That tells us, that proves the point that I'm trying to make, and the point is that you can place implants in infected sites predictably and very effectively without having to spend a lot of time and money on the patients. And all these statistical analysis tests were performed under this category, okay? And this is the most accepted one, we all know. So the average changes occurring in each parameters were 0.5, 0.08, 0.21, and we saw a facial bone width increase by about 0.3%, or 0.329 millimeters. We got 100%, 90% success with osseointegrated implants. We had 10% failures. And that failures, I cannot tell you why that happened. Okay? I can only speculate that it has to do something with the bacteria that was involved. But this is just a speculation. I cannot give you an exact answer why these failures have occurred. Okay? We are what we repeatedly do. Excellence then is not an act, but a habit. So if we get into a habit of doing certain things in a certain way and follow the protocols that have been laid or are being laid for the future, I think we will get nothing but good results at all times. Further research is always required, and I think we have to continue innovating and coming up with different ideas that can make implant dentistry more predictable and good for our patients. I thank you for inviting me here. If there are any questions at this point. Any questions? Yes, doctor.
Can you please speculate why, when you put the implant into the socket which was infected,
yes,
why the inflammation receded? Why it healed?
Why did it heal?
Why it
Here, yes. The number one thing is that when we talk about any inflammatory process in a tooth, associated with the tooth, what is actually happening at the cellular level is that there is a layer of, it's almost like a bag formation, okay? And that protective bag is actually preventing that infection from invading the bone, really. It's a protective covering that is caused. basically infection is, the pain comes from the inflammatory process and not because of infection. It is the inflammation that is causing the pain. So now our thought process is that in a normal socket healing, what happens? If you look at the studies from Lindy, from Schrapp, and all these other people who have published papers after papers, you look at the studies, they will tell you if you did not irrigate or curette an infected site that contains only inflammatory substance in it, it will resolve by its own. And that was what was very encouraging for me, to read all that literature and say, okay, most of it is mainly inflammatory. So if I can go in with my drill, leave the periosteal cells intact in the socket, and during the drilling process, I might get lucky, and I might get that inflammatory process in that drill, and it will irrigate out itself. So this was the hypothesis at the time. But we have proved it because we have a certain protocol that we follow to get success in this thing. So to answer your question, it is basically an inflammation that we are dealing with caused by infection. So if we remove that inflammatory process away, you get nothing but good, viable bone and cells that will help, that have a great potential for osteogenesis.